welcome back. Please accept our deepest apologies for the delays. So the lecture will be continued. Professor Kim.
Well, sorry for the interruption. I'm back to the index side. I'll talk about the robot company and the endocrine surgeon and the ISOPES. According to one report, estimated global surgical robot market size estimated to 6.3 billion US dollar in 2021, and will be growing with the annual growth rate about 14%. Will reach $15 billion US in 2012. General surgery is valued around 1.9 billion US dollar and expected to grow at the highest level. Of course, the head and neck is involved here. So robotic surgical system platform can be classified by the platform size, large, moderate, and small size. Because the small size platform mainly used in the endoscopy and the small minus procedure, I'd like to focus on the large and moderate size. As you know, the Da Vinci surgical system is the leading robotic surgery platform with diverse surgical indications. The use of Da Vinci has increased dramatically and become the most well-known robotic modality. With woman-mounted forearms and endolist and high-resolution 3D visualization as comfortable use of interface, it has enhanced surgical precision and dexterity. The major drawback is its cost and the size and the loss of haptic feedback. Recently, fourth generation Da Vinci SP system is used in endocrine department, especially it is good for the transaxillary approach. The SEANCE system is console-type robotic platform, FDA approved in 2017, consists of open remote console, control station, and four manipulate arm, each mounted on their own cart. It has an advantage over Da Vinci. It has haptic feedback and eye tracking software, but it is also large size and expensive. Bitrag system is developed in 2018, consists of a single cart with 3 robotic arms and open format surgeon console. With the 3 arms, it offers a hybrid surgical approach with a combination of robotic and laparoscopic instrument. The advantage of this system is small size and estimated and low cost. Level I surgical system is surgical robot developed in Korea, gained approval from Korea in 2017, and the robot is almost identical to Da Vinci system SI model. One significant advantage of this system is it has haptic feedback. The cost is still unknown. Hinotori is the product of a Japanese company, get a Japanese approval in 2020, and the component is composed of surgeon cockpit, operation unit, and vision unit. Let's move to the moderate size. Versius is a UK-based surgical robotic company product, has an independent arm, each with its own bases. They are small and light enough to be moved around an operation table. It has a haptic feedback. The spider system includes a bedside platform with multiple features, a kind of single port system. But this system was discontinued and sold to the China company. Another type is microsurgery. It is a telemanipulated robotic system for microinvasive surgery, consisted of 3 to 5 individual mounted minimal invasive robotic arm, allowing customized to the surgeon. And it has a haptic system and relayed with a telemanipulator. This Strauss system is modulated flexible endoscopic system with instrument capability for the single-port intraluminal surgery. The major advantage is its small size. For this presentation, I requested Johnson & Johnson and Medtronic for any information about the robot system for the company. The new Ottawa system is the product of Johnson & Johnson. The arm provide more control and the flexibility in the surgery, while arm will be integrated in the patient arm. But the system is still confidential. There is no information further. It has a platform that has a zero footprint designed to enable the patient access. Here is the Medtronic Hugo system. This is the video clip from company.
We started with a purpose: to bring robotic-assisted surgery to more people in more places than ever before, and to make quality care a possibility for patients around the world. Now, that possibility is at hand. Meet Hugo, a solution that's changing what it means to perform robotic-assisted surgery.
Medtronic Hugo's last system is built in flexibility with modular upgrade system. The Hugo Cart with car stores, vision, belly lab, FT10 generator. It just get a FDA approval, US FDA approval just before this conference. So since the introduction of the Da Vinci surgical system in 1999, the US FDA approval in 2000, Intuitive Surgical has no doubt played a significant role in the robotic surgical market and maintained a considerable market share for a significant period, with the original Da Vinci patent expired in 2019. Many robotic surgical system has been developed, and the clinical trial has been performed in various countries. As this robotic area, we will see intense competition as the company continues to develop and market new devices. New systems seek to improve on the Da Vinci surgical system through 3 main avenues: novel technology, reduced cost, and size reduction. Let's move to the endocrine surgeon's idea. For more than 2 decades, various types of robotic and endoscopic approach was designed by excellent endocrinologist and surgeon. And among them, we have reviewed yesterday about 3 main procedures: BABA, transaxillary, and transoral. I'm also the BABA user and having and some experience of transoral approach, but it is I'm a beginner of transoral approaches. Several years ago, I added and modified version of BABA technique, so-called, I call it bilateral axillary approach. That is moving the areola incision to the axilla side. This approach is similar to the BABA approach, but It is especially good for the patient who do not want any incision over the breast areolar incision, such as the patient who has breast cancer history or who has a breast augmentation surgery. And still use this technique and give the patient the option. What do you want? Some patients want BABA. Some patients want bilateral axillary approach. There are abundant published evidence on the robotic surgical thyroidectomy. Many evidences I'd like to introduce one review article. The other articles are similar to this article. This is the systemic review and the meta-analysis performed on over the 5,000 cases from 23 publications. It's from 2010 to 2016 in all the 5 surgical approaches, 8 transaxillary approach, 9 BABA approach, 4 GUA. GUA means gastrus unilateral axillary or gastrus unilateral axillobreast, and 1 bilateral axillary approach. Most of data is from Korea, about 22 cases from Korea, 1 from the United States. As you expected, the operation time for the robotic surgery is longer, no matter what type of operation you did, total and less than total hemisthyroidectomy. Post-op serum thyroglobulin level is higher in the robotic group. That means during the robotic surgery, we leave some thyroid tissue behind to protect the nerve or because of the lack of skill. I don't know, but many surgeons try to leave some thyroid tissue to protect, to avoid the nerve injury. Cosmetic satisfaction is good because many patients do the robotic surgery due to this lesion. Number of retrieved lymph node is smaller in the robotic group. In summary, you can say because almost all the review article says like this, complication rate is equivalent. Hypocalcemia, nerve injury, and other voice handicap index is similar. Surgical completeness is also similar. The only superiority is cosmetic satisfaction and the slow swallowing impairment. There is so many inferiority. It needs long operation time, small number of retrieved lymph node, high post-operative tissue level, high total drain amount. Now, we saw robotic system is feasible and safe. We know all about this. It's time to make any superiority over open surgery. In 2019, similar but slightly interesting report was published in Korea, from Korea, that shows some potential superiority over open surgery. They also investigated the propensity score matching comparison study between 2 open and robot. There is a 246 open patient and 123 patient. The patient number is not many, but it has similar result for the complication rate, but operation time is, as you know, is longer than open surgery. The surgical completeness is similar, but they showed the interesting result. The median parasite and the laryngeal function recovery time is shorter in the robotic group than the open total thyroid group, and this faster recovery result from the direct advantage of robotic surgery. It is due to the delicate and high precise manipulation by the surgeon-controlled forearms that prevent any unpredictable tension, traction, or any injury, especially by the assistant in open surgery. At this point, let's find what patient really want. Oncology outcome is most important. Every surgeon, patient will agree with this. Complication and sequelae is also important. There should be no complication. Pain, it is important, but many patients can stand and endure if it is temporary. Cosmesis is important, but to some patients, it is not an issue. I'm saying that at this age, it is not important. And cost is important, but some patient who is on the cover of insurance, it is not important. Every time I see the patient asks me, what do you recommend? But I didn't say, robot is superior to open surgery because there is no evidence till now. So you can choose what you want. How can you applicable robotic surgery to more people, more patients? Is it possible? Robotic surgical system is evolving, as you know. It's gonna be cost will be down soon, hopefully to the laparoscopic level. It is on the company's role. The next step is we should overcome the limitation of robotic surgery and find any superiority and develop any superior aspect of this procedure. Then we can widen the indication of robotic surgery. It is possible to, we can divide it into two sections. There is any possibility to overcome. As robotic system evolves and demand increase, the cost will be down. As shown in the literature, improvement of technique can reduce the complication, recurrent laryngeal injury, and the hypoparathyroidism will be better than the open surgery. You can see the possibility. Surgical outcomes will be improved with the technique improvement. There will be the retrieval lymph node will be going up, and the postoperative serum level will be down. And we can extend our indication to the more people. But there are several factors that hard to overcome. Basically, it is designed to hide the neck scar, extensive dissection, and the long operation time is inevitable. The drawback cannot be improved in spite of the advent of robotic system and surgeon's skill. And it is still hard to replace open procedure, even though price is down to the open thyroid state. Although the operation time that needed in the procedure different from each step, I can divide the procedure into 5 steps. Positioning and docking, closing time for the procedure will be slightly longer than the open procedure, but it is not so different from the open surgery. The most important and the most time-consuming steps are flap formation and consult time. The flap formation is a unique step for the robotic thyroidectomy. As we fully understand, this is the basic cause of long operation time and in remote access approaches. Consult time can be longer than in robotic thyroidectomy. However, the consult time is not unique to the thyroidectomy patient. And it can be shortened even more superior to the open procedure in selected patients. Therefore, we can notice that the flap formation is the main obstacle for the shortening of operation time. No matter what kind of approach you use, the remote access approach is inevitably need more extensive dissection, pain, and cause a long operation time. So I'd like to suggest the principle. Do not stick to the principle that my approach is best and no scar in the neck. Each approach has its own difficulty. Although you are already an experienced surgeon in the robot surgery, you may have no difficulty in doing your approaches, but because not all surgeons are experienced, so talented like you, every approach has its own area of difficulty. For example, Baba approach has some difficulty in doing the inferior side dissection. Transaxillary has contralateral difficulty. Superior side is difficulty in transoral surgery. So we can combine the various approaches like this. For example, Baba technique can be improved by using adoption of a transoral approach that can overcome some difficult case. How about adopt a small incision? It may be 1 or 2 centimeter or 2 or 3 centimeter, avoiding the midline area. The midline area is the most hypertrophic prone area. 1 or 2 robotic arms and self-retractor can be inserted through this incision. Through this mini incision, we can overcome many difficult points encountered in robotic surgery. We can make operation space on site with this incision within minutes. I've tried to do this through this incision. It takes less than 10 minutes. Decrease pain and decrease extent of dissection and remove the remote associated related complication, such as mental injury or the shoulder pain. We can also manage the difficult situations such as breathing easily on demand. So we can, if it is necessary to convert to the open situation, it can be done very easily. And so we can broaden our indication for the robotic surgery to more advanced stage. The only drawback of this approach is the presence of neck scar. But because the scar located in the lateral area, it will be not so noticeable and can be managed by skincare. So now it's time to bring new option. Yesterday we saw the most of patients go for the open surgery. About 90% of patients to choose or go for open. Only 10% of patients want to or go for robot surgery. If we adopt hybrid robot system, many portion of open patients can select the hybrid robot system. I'll introduce ISOPES. ISOPES is the International Society of Oncoplastic Endocrine Surgeons. The Society of Surgeons who are interested in performing endocrine surgery with minimal scar and maximum oncologic outcome. We have two domains in the homepage. Our mission is like this. We are founded in 2013. First president is Young-Yoon. Second, ISOPES is held in Busan. Third, held in Hong Kong. Fourth, in China, Hangzhou. Fifth, in Lucknow, India. Now it's time for the sixth ISOPES in Seoul. We have proctorship programs, and many doctors from the world visit Korea for learning the Baba technique. Now, growing number of endocrine surgeons want to learn robotic and endocrine surgery. As I mentioned during the opening remark during the last ISOPES conference in India, we are requested to organize society-based protocol. Because Korea has many experienced endocrine surgeons mastering various techniques, we started to build a credential program. At the end of 2019, ISOPES signed MOU with Intuitive Surgical for cooperation. Because international communication is limited during the last pandemic season, we did not proceed this valuable project. Intuitive Surgical robot company has its own role, and ISOPES has its own role. We need to do the case observation and prototype program. The primary goal of a credential program is to improve patient protection and care, not for the society, not for the company. Basic product training program should be on the company, but utilizing system on surgery must be done by surgical society. This program should be highly recommended to the members. Credential program consists of three components. Previously, proctorship program conducted individually and very limited in option. We can choose only one option, but after arranged by ISOPES, we can provide system program and establish credential and assign to the tutor with proper criteria. Before this, no regular observation weeks was permitted especially for the international surgeon. But working together with Intuitive, we can arrange and advance our program. And there is no library, but we plan to make a library to watch the video. Training can contact with Intuitive Surgical or ISOPES and submit and register. Then ISOPES will arrange the next procedure, attending, watching, and start the cases. We have around about 9 proctorship case observation sites in Korea. The training pathway will be like this. You can get a certificate after you are qualified. We will have, this is not is under construction. We will have a media-based library, and we will use YouTube as start from basic to advanced surgery, and we will. You can see the example from the beginning state to the expert state. After if you want, you can extend your training here to up to the 6 months. Thank you very much. Thank you for your attention.